TE series. Today we'll see TE for pediatric and congenital heart disease, basically considering the mitral valve. So now the general considerations while evaluating the mitral valve in pediatrics. The evaluation of AV valves presents a lot of challenges for number of imaging modalities. Why is this so? Is because anatomically the AV valves are thin, complex and highly mobile structures that are constantly in motion throughout the cardiac cycle. So accurate real-time imaging of these valves requires high degree of spatial and temporal resolution coupled with rapid processing and display of information. The difficulties of accurate imaging are further compounded by the rapid heart rates which are found in the pediatric population. So given the above challenges, echocardiography with its excellent spatial and temporal resolution is by far the most useful imaging modality for evaluation of the AV valves. TE further enhances these advantages because of the close proximity of the esophagus to the heart and particularly to the AV valves. This also allows for superior color flow and spectral Doppler evaluation of the AV valves, and this capability is essential for the complete assessment of the AV valve physiology and function. It is the best modality to assess repaired AV valves too. And further, the emergence of 3D TE has aided immeasurably in the comprehension of complex AV valve disease. This technique allows visualization of an AV valve from a number of different perspectives, some of which are unique to 3D imaging. This in turn enables the examiner to develop a much more comprehensive understanding of the AV valve anatomy and function, and can also facilitate surgical planning and management. So general considerations regarding transesophageal imaging of the mitral valve. Understanding the morphology and mechanisms of stenosis or regurgitation of the mitral valve is critically important prior to surgery. This is particularly applicable to growing infants and children in whom mitral valve repair rather than replacement is the goal. So these are some of the features which we use while assessing the mitral valve. So basically we see the supravalvular region first, the valve morphology of the leaflets including thickness, presence of any form of deficiency or dysplasia or underdevelopment or any motion abnormalities. We see for any clefts, we see the commissural areas. We also assess for presence of any accessory tissues, and then subvalvular apparatus including the cords and papillary muscles. Hemodynamically, we assess the severity of the stenosis or regurgitation. Stenosis is assessed basically by, we see the mechanism of stenosis, the level of stenosis where there will be flow acceleration. We assess the severity by mean gradient or pulmonary vein flow pattern. And in case of MR, again we see as to what is the mechanism of MR. We also assess the severity by using color flow, continuous wave Doppler, signal of the jet, vena contracta, PISA, and again the pulmonary venous flow patterns. And we also see the secondary effects of these lesions. So congenital anomalies associated with mitral stenosis or regurgitation, they can primarily result in mitral stenosis or regurgitation. And it is important to recognize that mitral valve apparatus not only consists solely of the mitral valve per se, but also includes the supravalvular region, including the left atrium and left atrial appendage, the mitral valve leaflets, the annulus, cords, papillary muscles, and the LV. So first coming to mitral valve dysplasia, this lesion has been described to represent a spectrum of disorders resulting in anatomical or functional obstruction to the left ventricular inflow. Most commonly, it is found within the context of mitral valve hypoplasia associated with Schoen complex or in combination with other congenital pathologies like coarctation. Congenital MS is usually characterized by abnormalities of all the valve components, and as such is defined by dysplasia of entire mitral valve apparatus, that is thickened valve leaflets with rolled edges, short tendinous cords, and obliterated intercordal spaces. This lesion can also occur with papillary muscle underdevelopment. Left heart disease associated with pulmonary hypertension and inadequacy of the left heart to support the systemic circulation are the most significant clinical consequences. Management considerations. Interventions are necessary when obstruction is significant enough to cause symptoms, or when there is progression of secondary effects such as pulmonary hypertension. Surgery is the preferred intervention in infancy. Various surgical approaches which are used to treat are commissurotomy, splitting of the papillary muscles, fenestration of subvalvular arcade, thinning of the papillary muscles, replacing the tendinous cords with polytetrafluoroethylene cords, resection of any accessory papillary muscles and secondary muscle attachments, resection of secondary cords, have been used in combination to relieve the underlying problem. Regurgitation can be worsened following aggressive intervention on mitral valve, so this should be kept in mind. If the left heart structures are not just capable of supporting the systemic circulation, then single ventricle palliation is opted for. So now coming to TE findings, they basically consist of thick dysplastic and hyperechoic valve leaflets, a restricted funnel-shaped opening of the mitral valve, and stiff movement of the leaflets due to short, thick tendinous cords with valve doming during ventricular diastole. Introducing the probe further into the stomach will permit visualization of the subvalvular apparatus for delineation of the structures of papillary muscles in a transgastric mid-papillary short axis view. The transgastric long axis view is ideal to assess the subvalvular apparatus, cords and muscle anatomy, length and insertions. Annular diameter is also assessed, and color flow Doppler should be applied to determine the level of obstruction, severity of stenosis, and define the direction and width of the color flow jets across the stenotic mitral valve. In children, the diastolic period is relatively shorter than in adults, and the classical feature of mitral stenosis are not easily reproduced. Furthermore, the diastolic period of ventricular filling is substantially shorter in affected infants because of faster heart rates, and the pressure decay is too short for measurement of the pressure half time to assess the severity of MS. The E and A periods are often fused, and the atrial contraction is more important in the young patients. The most frequently observed signal is the elevated peak A wave on the Doppler tracing. Clinically significant mitral valve obstruction is suggested when the peak inflow velocities exceed 2 meters per second. Frequently, if an atrial communication and multiple levels of left-sided obstruction, the assessment of the severity of mitral stenosis by evaluation of the transmitral gradient is challenging because the high pressure gradient may not be generated even in presence of severe obstructions if it is associated with the above conditions. Now coming to parachute mitral valve. The cardinal feature of true parachute mitral valve deformity is the insertion of all the cords into a single papillary muscle. The terms parachute-like asymmetrical mitral valve has been used to describe cases where there is marked asymmetry of the size of the papillary muscles with the bulk of caudal attachments into one papillary muscle, usually the posteromedial one. So the papillary muscle is typically elongated, located higher in the LV with its tip reaching the annulus and attached at both its base and the lateral side of the LV wall. A parachute mitral valve frequently coexists with supravalvular mitral ring, subaortic stenosis, and coarctation of aorta constituting the Schoen's complex. In this picture, you can see the transgastric basal short axis view showing the mitral valve end face. So here, you can appreciate only a single papillary muscle which is supporting the mitral valve. Management considerations. The management of patient with stenotic parachute mitral valve is impacted by the nature of associated lesions as well as the valve itself. One of the challenges is the repair of the parachute mitral valve is that the pathology lies within the caudal support apparatus, making surgical visualization difficult. The papillary muscle may be split to the level of ventricular wall in a plane that provides most subvalvular space. Commissurotomy may also be undertaken to increase the effective surface area of the valve orifice. TE findings. In the mid-esophageal 4-chamber and 2-chamber views, there is restriction of the valvular opening and movement of the leaflets which appears echogenic and thickened, resulting in pathognomonic pear shape of the valve, with the left atrium forming the larger base of the pear and mitral leaflets the apex. In a mid-esophageal long axis view, the valve has a typical domed appearance in diastole, and funnel-type narrowing may be observed due to the obstruction of blood flow to the caudal support apparatus. In the transgastric basal short axis and transgastric mid-papillary short axis views, only a single papillary muscle or the dominant muscle is usually confirmed. In a transgastric long axis view, the subvalvular apparatus can also be assessed, and it may be feasible to appreciate the tendinous attachment to the papillary muscle as well as the size and dominance. Next is supravalvular mitral membrane. The supravalvular mitral membrane is a fibrous ring ranging from thin to thick membrane located on the atrial side of the mitral valve, which produces a variable degree of obstruction to the LV inflow. Strong association with the parachute mitral valve, coarctation of aorta and subaortic stenosis is seen. Restriction of motion of the posterior mitral valve leaflet is a frequent early sign. The membrane is often present in the funnel of the valve on its atrial surface rather than being supravalvular in nature, but is also seen at the annular level. So in this, you can see this is the mid-esophageal 4-chamber view showing a thin membrane just above the annular plane, which is a supramitral membrane, and color flow Doppler interrogation shows flow acceleration in the area of the supramitral membrane. Management considerations. Surgery involves removal of the membrane in its entirety. It is important to remove all the components of the ring to relieve restriction of the mitral valve leaflets during diastole. The mitral valve leaflets, papillary muscles, and subvalvular apparatus are inspected for any evidence of associated disease. Papillary muscle splitting may be required as the pathology is frequently associated with parachute mitral valve. Associated lesions should be addressed. TE findings. The membrane can be difficult to detect because it lies within the atrial surface of the valve leaflets, usually within 1 to 3 millimeters of the mitral valve annulus. The membrane may prolapse into the mitral valve orifice during diastole. Color Doppler interrogation of the area will demonstrate aliasing starting above the level of valve and interrogation with pulsed wave Doppler at various levels to the mitral valve inflow, that is above the membrane, between the mitral valve leaflets and below the level of the valve, may help detection of level of maximum obstruction, although this can be difficult to determine due to proximity of the membrane to the valvular leaflets. So this is a 3D TE view of the mitral valve end phase seen from the atrial side. So you can see the mitral valve down, which is seen in blue hue, and on top is the supramitral membrane, which is represented by arrows. Double orifice mitral valve. Two complete orifices of the mitral valve supported by their own tensor apparatus is the hallmark of this abnormality. Usually it is associated with other defects such as AVSD, aortic coarctation, interrupted aortic arch, or complex congenital heart disease. 3 types of double orifice mitral valve have been described based on the site of accessory orifice, which may be located at the anterolateral mitral valve commissure, at the posteromedial commissure, or there can be equally sized orifices with a central fibrous bridge. TE findings. The double orifice mitral valve can be identified in the midesophageal and transgastric views. Rather than ellipsoid shape of the normal mitral valve, the double orifice valve has opens as 2 circles in diastole. By moving the probe up in a sweep from apex to base, the 3 types of double orifice mitral valve can be identified. The orifices of complete bridge type are seen throughout the scan, while the incomplete bridge type, the orifices are seen only at the level of papillary muscles. In the complete bridge type, the smaller or accessory orifice is seen about the mid-leaflet level. The midesophageal views are used basically for assessing the degree of obstruction of the across the mitral valve and left ventricular outflow tract if present by spectral Doppler interrogation. Color flow Doppler demonstrates the relative velocities through orifices and reveals the division of flow into 2 streams entering separate orifices. Now coming to mitral arcade. Mitral arcade was initially described by Lehman and Edwards in 1967 as an anomaly of the mitral valve that consisted of an adequately sized mitral valve orifice, continuation of the papillary muscles to the anterior mitral leaflet, either directly or through interposition of unusually short fibrous cords, and better differentiation of the cords attached to the posterior papillary muscles. So anatomically, this form of mitral stenosis involves obliteration of the tensor apparatus of the mitral valve, and there is continuation of valvular tissue onto the papillary muscles with loss of intercordal spaces in such a way that it can be difficult to determine whether the leaflet ends and where the leaflet ends and the papillary muscle starts, as there is vascularization of the subvalvular apparatus. These patients usually present with signs and symptoms of mitral stenosis. However, restriction of the mitral valve movement can lead to regurgitation due to failure of cooptation of the leaflets. Management considerations. It is considered to be the most difficult mitral valve malformation to repair because of involvement of the valve leaflets, lack of true caudal support, and abnormal papillary muscles. Technically, surgical repair of this abnormality requires extensive valve reconstruction that can include removal of fibrous tissue, creation of artificial supporting structures, splitting of the papillary muscles, commissurotomy, or fenestration of subvalvular arcade or annuloplasty. The final goal is to leave enough fibrous support so that the leaflet does not prolapse. If necessary, artificial chordae of PTFE can be created. TE findings. Features include absence of visible tendinous cords between the leaflet edges and papillary muscles. The intercordal spaces are absent with continuity between the papillary muscle and the free edges of the leaflets. Characteristically, a continuum from valvular tissue to thickened papillary muscles is seen by using a combination of views by which mitral valvular tissue and papillary muscles can be defined. The cords are usually short and thickened with obliterated caudal spaces, or they might be totally absent. So this is a 3D TE picture of the mitral valve from the LV aspect. So here you can see thickened dysplastic mitral valve leaflets along with thickened papillary muscles, and there is a fibrous bridge connecting both the papillary muscles, which is showed with asterisks. Coming to congenital mitral valve regurgitation. Mitral valve regurgitation can be classified either as primary due to underlying malformation or secondary to other disease processes. In the pediatric population, LV failure, secondary to cardiomyopathy, myocarditis, or anomalous origin of coronary artery, or acquired diseases like endocarditis, rheumatic heart disease, or systemic degenerative diseases are the leading causes of secondary mitral regurgitation. Congenital lesions such as mitral valve prolapse, cleft mitral valve, double orifice mitral valve, straddling mitral valve can be associated with MR. Management considerations. The general concept is that repair of congenital mitral valve regurgitation allows undisturbed somatic and valve growth, delays or obviates the need for any future valve replacement, and avoids anticoagulation. TE findings. Accurate quantification is influenced by loading conditions, influenced by level of sedation in GA. In pediatric everyday clinical practice, qualitative assessment is used most commonly with the left atrial and ventricular size, vena contracta, and regurgitant jet size are considered as important part of assessment. Localization of regurgitant jets can be done from the mediasophageal and transgastric views, and it is important to interrogate these from multiple views. Continuous wave Doppler with analysis of spectral pattern and the density, and pulse wave spectral Doppler interrogation of the pulmonary veins are also important. 3D echocardiography provides important visualization, improved visualization, and exact quantification. So this is a picture showing mitral valve with thickened valve leaflets which are prolapsing, and there is failure of coaptation of the leaflets, which will give rise to MR. Isolated clefts of the mitral valve. It is associated with different forms of congenital heart disease, including VSDs, DORV, TGA, tricuspid atresia, etc. Mostly they involve AML. The papillary muscle position is normal or near normal for an isolated mitral valve cleft, in contrast to counterclockwise rotation observed in AVSDs when viewed from ventricular apex. The affected leaflet is often dysplastic with rolled and thickened edges. Management considerations. Repair is considered based on the severity of MR. Most common method of repair is by using interpreted suture technique. Annuloplasty is performed if there is dilatation of the annulus. So this is again transgastric basal short axis view showing AML and PML. So you can see a cleft in the AML. TE findings. In the transgastric basal short axis view, the cleft is seen as a slit-leg deficiency in the anterior mitral leaflet pointing towards the LV outflow. Real-time 3D display displaying the equivalent of transgastric basal short axis view at the level and face view will clearly show the cleft, including its boundaries and extent, as shown in the adjacent figure. Sweeping towards the apex to the level of transgastric apical short axis view, this allows visualization of caudal support apparatus. Caudal attachment supporting the edges of the cleft connects them to the ventricular septum and subsequently may create subaortic obstruction. With a ventricular septal defect, the cord attaches to the crest of the septum or may be traced to a papillary muscle anchored within the right ventricle, causing straddling. These are better visualized in the mediasophageal views. Now coming to straddling of the mitral valve. A straddling mitral valve is characterized by caudal attachments and papillary muscles into both the left and right ventricles. Thus, the presence of a ventricular septal defect is a prerequisite for straddling. Malalignment between the outlet, that is conal septum, and the muscular ventricular septum is also frequently observed. Straddling of the mitral valve is most commonly seen in conotruncal malformations such as TGA or DORV, where it has a major impact on surgical approach, particularly if the anatomy is just suitable for a biventricular repair. Management considerations. It is a major surgical challenge to obtain a biventricular repair. Surgical repair can involve sacrificing the chordae while at the same time not creating a flail leaflet. Major risks include causing MR, AV block, and outflow tract obstruction. TE findings. Frequently in hearts with abnormal ventricular-arterial connections and is almost always associated with a cleft in the anterior leaflet, resulting in variable degrees of regurgitation. Valve may have chordae inserting into the crest of the interventricular septum or the lateral wall of the contralateral ventricle. So, in the former situation, a biventricular repair should be considered, but in the latter conditions, single ventricle palliation is usually opted. So, the adjacent figure is showing deep transgastric view with the straddling of the mitral valve, which is seen across the VSD. 2D echocardiography provides superior detail with imaging fine chordae, but it is suboptimal when attempting to determine the spatial relationship of these structures in 3D space. Detailed evaluation of subvalvular apparatus is imperative in this condition. The best views to assess the extent of valve straddling and cleft are the mid-esophageal 4-chamber, 5-chamber, long axis, and transgastric basal short axis, and deep transgastric views, which sweeps from anterior to posterior planes to demonstrate cross-sectional images of the ventricles, interventricular septum, and the outflow tracts. Degree of straddling is important in determining the repair. Now coming to mitral valve prolapse. Mitral valve prolapse is defined as an extension of leaflet segment beyond the annular plane. It is associated with connective tissue disorders like Marfan's, Earler Danlos, but may be associated with other congenital heart anomalies. When seen in connective tissue disorders, typically there is prolapse of both the anterior and posterior mitral valve leaflets due to combination of leaflet redundancy and annular dilatation. In adults, mitral valve prolapse has been classified as classic when systolic displacement is more than 2 mm and maximum diastolic leaflet thickness is more than or equal to 5 mm, and non-classic when the prolapse exists when the displacement is more than 2 mm with maximum leaflet thickness of less than 5 mm. Management considerations. Surgical intervention should be considered in case of clinical symptoms and moderate to severe MR. Mitral annuloplasty, leaflet reduction, chordal transfer, insertion of artificial cords, and edge-to-edge repair using Alfieri stitch. So in this picture you can see that there is prolapse of the mitral valve leaflets causing MR. TE findings. The prolapsing segments of the mitral valve leaflets can be seen in almost all mid-esophageal and transgastric views. 3D echocardiography offers the advantage of facilitating visualization of the mitral valve in an in-phase perspective from either the left atrial or left ventricular aspect, allowing accurate identification and quantification of prolapse of individual scallops and segments of the mitral valve leaflets. Last is infective endocarditis. TE is also very important for diagnosing infective endocarditis. The vegetation is seen as a echogenic structure which is attached to the mitral valve in the figure. Thank you.